Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. GP Online is the media partner for the RCGP annual conference, and this is a special episode from a very packed event here in Newport in Wales this week. Coming up, we're looking at what Health Minister Stephen Kinnock said about the BMA dispute over online consultations and what delegates thought about his speech. We also highlight what RCGP Chair Professor Kamila Hawthorne had to say in her speech. I'm talking to College Vice Chairs Dr Margaret Ikpoh and Dr Thomas Patel-Campbell about the results of the college's latest member survey, what they think about the 10-year health plan, and how the increase in anti-immigration and right-wing rhetoric is affecting GPs. Later on, I'm speaking to RCGP Wales Chair Dr Rowena Christmas about being the subject of a book that tells the story of rural general practice. And I'm also talking to outgoing RCGP President Dr Richard Vautrey. You can find all of GP Online's coverage from this week's conference at GPonline.com/RCGP. This episode of Talking General Practice has been supported by Simprove. Based on an external survey of 432 healthcare professionals, Simprove was the number one probiotic recommended by gastroenterologists, dietitians and GPs. The unique water-based solution delivers live bacteria to the colon and is proven in randomised controlled trials by leading institutions. 92% of people report a benefit within 12 weeks in real world. Healthcare professionals can trial Simprove for free. Visit professionals.simprove.com and sign up for a virtual meeting to hear more about the research behind Simprove and get your free 12-week pack. That's professionals.simprove.com. The conference opened on Thursday morning with a speech from Professor Kamila Hawthorne, the RCGP chair, who spoke about the unsafe workload GPs are facing and concerns that the 10-year plan could pile yet more pressure onto practices. She called for the government to introduce a primary care investment standard to guarantee funding increases for general practice in the coming years and additional ring-fence funding to ensure practices could recruit more GPs. Here's some of what she had to say.
Our most recent member survey shows that many of you are worried about neighbourhood health services proposed in the plan, concerned about GP shortages, increased workload, unclear funding plans, and the future of GP partnerships. I understand that apprehension completely. When your workload is like a river that never stops flowing, no matter how hard you work, no matter how many hours you put in, it is difficult to have the mental capacity even to think about long-term strategy. And many who do grapple with it say they're caught between hope and scepticism. They're hopeful because the aspirations in the 10-year health plan make sense. They're sceptical because they've heard similar hopes expressed before. It's an outrage that general practice receives less than 10% of the total NHS budget while providing the vast majority of patient contacts. Worse still, it's inexcusable that our share has been falling despite an ever-increasing workload. After years of campaigning, we're pleased that the 10-year health plan promises to reverse this trend so that the ratio of NHS expenditure on hospital care will fall with proportionally greater investment in out-of-hospital care. We accept that there cannot be an overnight transformation and take heart from the promise that this will happen by 2035, and we will hold them to it. But the devil is always in the detail. After years of underfunding, we need a sustained increase in core funding, and we're calling for a primary care investment standard that mandates yearly funding increases. If GPs are to provide expanded services to patients as part of the new neighbourhood health service, it's a no-brainer that we will need many more family doctors. What is absolutely clear is that we need to recruit more GPs and work harder to hold on to those we have. And so we're asking members now to sign our new letter to Wes Streeting, calling on him to make sure the forthcoming 10-year workforce plan isn't another missed opportunity and instead delivers a clear roadmap to train, recruit and retain the GPs that we desperately need. This is not just about the impact on us. Crucially, it's about the impact on our patients. In our recent survey, 74% of our members told us that patient safety had been compromised by workload. Fewer than 30% said they'd had enough time during consultations, and more than half reported that their own mental health had declined in the last year. Perhaps it's no surprise that so many GPs plan to leave the profession, and that the biggest cause is stress, not retirement, but stress. It is such a waste to lose experienced GPs, and I've been explaining this to government for the last 3 years. At least now I'm told they understand the issue, but I still haven't seen enough improvement or movement to redress our retention crisis.
Some of the things Kamila was talking about in her speech reflect topics we talked about when I spoke to her for Wednesday's episode of the podcast, so do have a listen to that if you haven't already. The conference also featured an appearance from Primary Care Minister Stephen Kinnock on Thursday afternoon. In his speech, he officially launched the government's review of the Carr-Hill funding formula, which will be run by the National Institute of Health and Care Research over the next 6 months, and that was really popular with the audience. But he doubled down on the government's insistence that practices need to keep online consultation systems open throughout court hours. His speech was certainly robust, and he described the dispute with the BMA as a phony war in a Q&A session at the end. He accused the BMA of whipping up the issue and completely dismissed concerns about the impact that it would have on practice workload. Meanwhile, the audience responded with some incredulity when he said that for the first time in a very long time, GPs had a government who was on their side. There was certainly a lot of eye rolls from the people I was sitting next to in the auditorium. Anyway, here's what he had to say about online consultations.
So there is simply no getting away from the fact that we have to move with the times, and in particular make the shift from analogue to digital. And standardising online access and triage is a vitally important element of that shift. It is also key to our manifesto pledges to end the 8 a.m. scramble by widening the window that patients have to request appointments, and to bringing back the family doctor by, in many cases, giving patients the option to choose a specific GP when they make that online booking. And I'm grateful to the overwhelming majority who've enthusiastically embraced this move to modernisation. Of course, we fully understand that there are practices which, for varying reasons, are struggling to get their systems up and running. For them, we have put in place a mix of tailored support measures available nationally, both online and directly from ICBs. But ladies and gentlemen, what I simply cannot get my head around, and what we will not tolerate, is the rump of refuseniks and their cheerleaders in the BMA who are intent on whipping up this issue. And I suspect that patients are just as mystified. Here are the facts. We negotiated and agreed a contract package in February that included the requirement to have online access available throughout core hours. We agreed to delay the implementation by 6 months to give practices time to prepare. We established clear safeguards that mean GPs can divert those with urgent needs to the telephone, and we insisted that surgeries must remain fully accessible by phone and walk-in. So we are profoundly puzzled as to why this has suddenly blown up as an issue. The BMA claims that GPs are terrified. Really? And they say that patients are at risk from an avalanche of online requests that will lead to hospital-style waiting lists. But neither of these doomsday scenarios have so far materialized. Indeed, research recently published in the BMJ examining 10.5 million patient contacts found no evidence of supply-induced demand, with practices able to tailor care according to need safely and with fair prioritization. Even the HSSIB notes that significant benefits of using online consultation tools include improved access, reduced telephone call volumes, more effective allocation of clinical time, and improved health and well-being. So you can imagine how taken aback I was then to read one GP with 20 years' experience saying, and I quote, "The new system feels almost like modern-day slavery." I mean, come on. We're asking GPs to allow patients online consultations, and of course, you're entitled to your views on that and how it might affect your working practices. But to suggest that it is akin to being forced into prostitution or coerced to work on a cannabis farm for zero pay and zero control over your life, that is frankly too much and going too far. We're always happy to have discussions with the BMA to understand their concerns and to talk about how we can work through them together. What we will not do is unpick the contract that we agreed with them in February. Nor will we abandon modernisation and turn the NHS into a museum for 20th century healthcare. That would be a betrayal of the patients all of us here are fighting for.
Our senior reporter Kimberly Hackett went out to talk to delegates about what they thought about what Stephen Kinnock had to say.
Yesterday, Stephen Kinnock spoke to the conference. What did you think about what he had to say?
I actually think a lot of people who are speaking on this matter are not very qualified to be speaking on it. Unfortunately, including him last night, I was disappointed that somebody of such high standing has no understanding of what happens in a GP's working day and to give an opinion that actually drives policy.
So overall, I did get a positive message. I do agree the 10-year plan and looking forward to the new neighbourhood health contract, and neighbourhood health service is definitely the way forward because there is a definite need for integration, working closely with the partners and social care. So yes, overall it's a positive message and a lot needs to be done. I think the things like access needs to be proportionate, while there are merits to the online access rather. Now, it's easy probably on paper to say it's open for routine care from 8 to 6:30, but from a patient perspective, that interpretation can be quite mixed. So as a practice, as an example, on the very first day, yes, we opened till as per the guidance, but what we quickly realized were we were getting routine calls, and the best example was we had a mum who had put in a request under the routine care form, 4-year-old, earache and headache, and obviously if this was just to be triaged by an admin person, it potentially could have been something very significant.
Do you think the government is listening to GPs?
No, I don't think they're listening. I work in a practice where we were struggling with the 8 a.m. rush. And last year in November, we decided we're going to do total digital triage, where a patient can submit a request any time of day, and that request will be looked at by a GP. And that way, we stopped telling patients that we've run out of appointments because we could actually plan. And that helped us to be able to fit our demand to match it with our capacity to meet that demand. But we had to cap it, so we had to open it for specific hours of the day to allow the triaging GP and her team to take a break for lunch. Suddenly, the government wants this online platform to be opened continuously throughout our working day. That is not manageable. So when the government comes in and says they want to solve the 8 a.m. rush, we've solved it. And we've solved it in a way that we know works for us and the number of staff that we have to do the work. And now the government brings something else that we can't handle, and they've not given us the funding to create the capacity to meet that demand.
No, I don't think they are. I think they have their own message that they want to get out politically to suggest that they're making it easier for people to access GPs, but the cliche being that if the traffic jam's in the middle of town, what the government are doing is building an extra lane on the motorway, which isn't going to help the problem, will make the problem worse if anything, but they're chasing headlines rather than reality.
I'm really pleased to be joined now by Dr Margaret Ikpoh, who's the RCGP Vice Chair for Professional Standards, Training and Development, and Dr Thomas Patel-Campbell, the college's Vice Chair for Finance and Member Value, to discuss what's been happening on day one of the conference so far. Thank you both for coming to speak to me.
Thank you for having us.
Happy to be here.
We heard from Kamila, and it's her last speech as Chair of the college. And among other things, she was talking about some research the college has done recently that shows GPs are really concerned about the impact heavy workloads are having. And unfortunately, this isn't a new problem. What do you think needs to happen to address this?
So we are increasingly hearing this from members. The data you're referring to is from the member survey that goes out to all of our members. We know that members are saying that their mental health is being affected by the pressures of workload. There are lots of different reasons why GPs are finding themselves under pressure, and I think that we wouldn't suggest that there's one magic bullet that's going to fix everything. If we can see the things that the college asks for regularly of government, investment in general practice, clear retention strategies, acceptance of what workload is appropriate for us to do in general practice and actually what others could do, and some pragmatism with some of the positive stuff that's coming out from the 10-year health plan, things like left shift and us doing more work in the community. That'd be amazing. GPs want portfolio work, but we need some time and headspace to really do it effectively.
It feels like I'm going to be a little bit of a broken record here, because ever since I started with the college, these issues actually haven't improved. If anything, they've got worse. And so we find that the dissatisfaction is not just with our patient cohort, it's within our GP membership as well. And we will try everything we can do to obviously support our members. And one of the things I think Camila's called for was asking members to help us write a letter addressed to our health secretary to see if we can alleviate the burden that are on members and practices, so we can just deliver safer and better care for our patients. And so I think that's really important.
Are either of you concerned about recent changes to online access, which have led the BMA to declaring a dispute with the government will make workload even worse for GPs?
The recent changes have been more broadly about access in its entirety. It's not just online, but telephone and face-to-face as well. We have to be cautious because really this is something that is BMA territory. You know, the contract discussions with the government, we would simply ask that all parties come together to deliver something constructive that is in the best interests of our patients.
Yeah, and I think it's important to recognise there are actually practices who are out there that are already providing the online access for their patients. Where the worry lies, an understandable worry lies, because we all want to do this, but we all need to make sure that we're all adequately resourced to do this for the communities that we serve. Otherwise, we won't do it effectively, and at worst, it could be delivered with putting patient safety at the centre of all of this.
Camila also was talking about the 10-year health plan in her speech, and the college's poll found sort of widespread concern among GPs about the direction of travel, and particularly worries that there aren't enough GPs to deliver on what the government wants. What's your view on the 10-year plan? Do you think it's a good thing, bad thing? Is there anything you're concerned about?
I think it's important to have a plan. I think what's concerning at the moment, particularly with the current workforce, is the GP unemployment that we have, that we know it exists. And it's also the fact that we're in a space at the moment where we don't actually really know what numbers are required. I think we know they're in their thousands, but that number seems to fluctuate. But what we do know is we need more GPs. And so what we need from the government is a definitive number. Hopefully we'll have some evidence of this workforce plan before the year ends in terms of what is needed in the workforce, because we need more. But we know that in the summer there was a hint to suggest that actually there'll be less numbers that will be asked for, and I'm not sure how that's going to work in real terms when we know there's a high degree of burnout. We know that people are leaving. Every other week, Emma, I'm getting a request from GP registrar that's recently CCT'd wanting to go to Canada, Australia, or New Zealand. We know that this still happens. So how are we going to stop this outflux of GP members who are feeling very disenfranchised with the current system, because we need them to deliver any 5, 6, 8, 9, 10-year healthcare plan when it comes to fruition?
There are opportunities as well as risks in the plan, and it is a 10-year, quite high-level strategic plan. I think we hear lots of positive words said by government. They want to invest in general practice, they do want more GPs, that they want to move care into the community. All of these will be relatively uncontroversial to GP members, but I think it's the doing that we now need to see. We're in the first year of the plan. We're seeing that some of that work's starting to happen, but I think until we actually see some measures taking effect in pragmatic, realistic spaces, affecting practices positively, seeing services actually move to more appropriate community locations, there's still quite a lot of uncertainty, and I think that uncertainty causes anxiety to GPs who are simply wanting to deliver their highest quality care.
The anxiety is one size doesn't fit all. So I currently work out of an old 1930s build that every other week we need something repairing or fixing, or it's leaking. And so we need some real infrastructure funding into how we're going to manage our estates, because at the moment, because the workforce is diversified, quite rightly, you know, I've got a myriad of allied health professionals that help deliver care, but inadvertently what that's done is it's removed the space that we need for GPs to come and deliver the care that we need to our communities.
That's why our call in the letter to the Minister is a primary care investment standard, and it needs to be a broad investment standard. We need investment in our people, we need investment in non-GP support. We can't do the work that we want to do without non-GP clinicians and admin staff. We need infrastructure, we need funding for the digital solutions. It has to be broad-based, and we know that primary care delivers exceptional value for money, so that's where we would really want to see clarity and multi-year agreements on a primary care investment standard to make absolutely sure that it actually happens in the real world over the next few years.
Later on today, we're expecting Stephen Kinnock to come on stage. What would you like to hear him say to the conference?
I think what I'd like to see is how are they going to move those words into actions? Is there going to be some concrete detail around what sort of things they're looking for in the 10-year workforce plan? Are they going to share more concrete information about how they are going to move stuff into the community? So I think what we really want is just to see progress keeping forward. It is really good that the right words are being said, but we have to now get actions as well as those words.
What I'd like to hear, working in an area of marked deprivation, is the how, and in particular the how in terms of revision of the Carr-Hill formula. How are we going to bring some equity back into the system, in particular funding, so my patients have the same equitable access to funding as, say, someone in Chelsea?
One thing, obviously, Camilla's talked a lot, she talked on the podcast when she talked to me about, and she mentioned it today, was about GP retention. She seems quite frustrated to me that not enough has been done on GP retention. Do you think the government has been listening to the college with its calls for more of a focus on this?
I'm a hopeful, because without hope we don't have anything really, and we need to retain hope. One of the words that was repeated time and time this morning was value. I'm hoping they will see our sense of value to the community, and without the strong general practice, without strong partnerships, general practice will essentially fail.
So I think in the previous workforce plan, it was a glaring absence. We can't have a high-functioning cohort of highly specialised individuals if we're losing them to early retirement, moving abroad, deciding to do other things. I think that's where there's a huge opportunity in the next 10-year workforce plan, not just for numbers of new GPs, which is definitely something the college would continue to ask for, but also focus on how do we make sure we retain GPs so that we're putting the plug in as well as turning the tap on at the same time. We need both, otherwise we won't end up with more GPs to deliver the care we want to deliver.
The other thing I might say, which may be slightly controversial, forgive me Thomas, is what can we do as a profession? Because I think one of the words that was mentioned today was around kindness, and I'm mindful that sometimes as a profession we're not kind to each other. Only yesterday I was contacted by some really worried salary GPs who had no maternity provision in their contracts, and that hasn't come from a government, that's come from a GP. So I'm just going to call it out as it is. I think there's more that we can do as a profession to be kinder to each other as well, to enable that retention, because now they're thinking, well, if I can't get this here in the UK, I'm going to look elsewhere.
Yeah, and I just wanted to talk to you about something that you spoke about at the conference this morning, Margaret. You described your own recent experience of racism, and we're in the current climate that it's very charged around the issue of immigration. We've seen a real rise in far-right racist rhetoric. How has this all been affecting GPs? Are you worried about the impact this is having on doctors?
I'm really worried, particularly I'm mindful of the Islamophobia that's happening at the moment. It's stark, and we've had a few cases that have come in recently where GP surgeries and staff have been threatened and police have been involved. And I think we need to get ready, because I'm not sure this is going to get any better anytime soon, given the current geopolitics around this issue. And we need, as a college, to consider what avenues of support we can offer our membership. And I'm not quite sure the general public is aware of the ramifications of what's happening on the wider workforce, particularly with the NHS, where we exist to serve the population and care for them, enable their health to live the best lives that they can be. But that's not going to happen if people start questioning their value and worried about their personal safety, not just for themselves, but for their families too. So I'm extremely concerned.
It's very important for us to call it out in many ways. So individually calling it out, we are in positions of authority and respect as GPs. We have a strong voice that we can support, particularly those vulnerable individuals who don't feel they can call it out themselves. But also the college has an institutional powerful voice to say, no, this is wrong. And it isn't just that it impacts on GPs. We heard Margaret's comments earlier, which are very uncomfortable and distressing to hear. But it also unfortunately affects our non-GP staff, and it affects our patients.
The college has done a lot of work around the issue of international medical graduate GPs and visas, and you recently wrote to the new Home Secretary about that. Do you think this issue is ever likely to get sorted? What do you want the government to do to address this?
I mean, the gold standard would be to offer everybody independent, ILR status at the end of their training, and that's the best way I think we could retain them, essentially. And I've been asking for it for the last 4 years, and I'll just keep asking for it. Bola Oulabi, former NHS leader for health and equality, says, if they haven't heard you for the millionth time, you keep asking.
We need to make sure that we share what's most important here, which is that these are human beings who are under extreme stress because they're not sure, what country they're able to work in, whether they can get a job. It is an incredibly stressful period for them. So there's a definite human-centric set of values we need to be exposing here. But also there is an economic argument. There is an awful lot of financial investment to develop highly qualified, skilled GPs who are qualifying, who then are moving abroad despite wanting to stay. That is an absolute mad state of affairs given the financial pressures we hear. But I wouldn't want that financial argument to miss the human value that is also really important in this conversation.
We're very much at the start of the conference. What are you looking forward to over the next 2 days?
At a very basic level, just catching up with everybody.
Yes.
But for me, personally, as an educationalist, I'm looking forward to the GP trainer sessions because they're often a cohort that's forgotten about. People are taking on the role of being a GP trainer much earlier on in their careers. But as we know, there's different challenges that they have to face. And so I'm looking at ways of what we can do to engage them in terms of support for that cohort.
So for me, I always get 2 things out of conference. One is so many ideas when I'm on my way home from the conference. There's so much good information and training and educational development that is shared in conference. I'm really looking forward to thinking about how I can embed that in my practice day to day and more broadly with the leadership roles I have. But also just the positive energy. General practice is hard work, but it's really, really rewarding. But the positive vibe at every conference is absolutely amazing from, again, a wide range of members, and just reinforcing that positive energy while finding my tribe. I think that's really, really important. I always leave conference feeling uplifted.
Today at the conference, RCGP Wales Chair Dr Rowena Christmas took to the stage with author Polly Morland, whose book A Fortunate Woman captures what it means to be a rural GP in today's NHS, in particular the importance of continuity of care and relationships with patients. I spoke to Rowena ahead of this year's conference about that experience, her safeguarding work around county lines gangs, and the RCGP's Welsh manifesto, which was launched here at the conference ahead of next year's Senedd elections. Thank you for coming on the podcast, Rowena.
Thank you, Emma.
So we're speaking ahead of the RCGP annual conference. You're involved with a number of sessions on the programme at the conference this year. One of them is a plenary session in conversation with Polly Morland, who's a documentary maker and writer. Her most recent book, A Fortunate Woman, A Country Doctor Story, is actually based on you, isn't it? How did that all come about?
Yeah, it's quite a strange experience having your working life turned into a book. But yeah, Polly's book is about me and about my practice. It came about sort of almost as a companion piece to John Berger's 1967 book, A Fortunate Man, which was set in my practice as well. Polly spent about 6 weeks shadowing me in the practice, sort of looking at every part of my work and what I do. And the result is this very human portrait of rural general practice, looking at what's changed over the last 50 years and also what's stayed the same.
The book really makes the case for continuity of care, doesn't it? And why that's still so important even in modern day medicine. I mean, that's something that you're very passionate about, and you've led a lot of the work the college has done about relationship-based care. Why is it so important? And do you think, policymakers, politicians, do you think they understand the importance of it?
We're really trying to help them understand that. For me, continuity of care is just all about the essence of general practice. If you're lucky enough to work in a practice where you've got it, you are probably doing your job a little bit better than if you have to work out what's going on with every new patient. We know the evidence shows that doctors who have continuity of care tend to make fewer mistakes. Their patients tend to trust them more. They're more likely to follow advice, take their pills, get that vaccination, go out for that walk. And the GPs are less likely to refer them to secondary care. The patients are less likely to end up in the emergency department or out of hours care. And even patients are less likely to die if they know their doctors better. And the evidence for it is dose dependent. So it's scientifically validated. The longer you're with the same doctor, the better your outcomes are likely to be.
This episode of the podcast is going to be coming out after you've done that session with Polly at the conference, but can you give us a flavour about what you'll be talking about and what delegates will be hearing about?
Yeah, I think what Polly somehow managed to do was capture the magic of being a GP in a rural community, and I hope we'll be able to get that across to the conference. All of the joy that comes with that, the humour, the heartbreak, and also what I love, which is the intellectual challenge of the job. Lots about continuity, about how belonging to a place matters more than ever, really. And I hope that delegates have come away just remembering that the ordinary stuff that we do every day, every consultation, every relationship we nurture is a real gem. You know, it's an opportunity to change someone's life for the better. And that is just the beating heart of the NHS, really.
One of the other areas where you've done a lot of work in recent years is around safeguarding, and you've got another session on the conference programme, which is about county lines, street gangs and child exploitations. How did you become interested in this specific area of safeguarding?
Oh, it's such an alarming area. I think I had to become interested in it because it is one of the fastest growing threats to our children's safety in the UK. County lines gangs are exploiting children as young as 10 or even younger sometimes. They're getting them to move money and drugs from often cities into rural areas. We need to know about this because if we know about it, we can look out for it.
What are the key things that GPs need to know about that?
GPs have got a really key role. Patients come into our surgeries and they're a bit more likely to trust us, so they're a bit more likely to open up to us than perhaps a social worker or a police officer. We need to be looking out for the signs. Children might present with unexplained injuries, missing GP appointments, missing lots of school. They might come in a really expensive pair of trainers when before they've always been, wearing hand-me-downs from their big brother. Changes in their behaviour. All of those things are soft cues that we just need to be thinking, oh, I wonder. Grooming is tricky. The children might well not see themselves as victims at all. They might feel that they're very fortunate and they're choosing this lifestyle. They don't realise their vulnerability. We really need to know if we've got suspicions who we should be talking to, because that can be a real barrier in a busy morning surgery. That kind of, I don't even know what to do, can cause you to close your eyes metaphorically to it. And this kind of work, we need to be sharing concerns, working with other agencies, talking about it as much as we can so that we can try and help these vulnerable children. So I think the key is to stay professionally curious, always be thinking, what if, think the unthinkable, and then share concerns early.
People will know you most as being chair of the Royal College of GPs in Wales, and the conference is in Wales this year for the first time. How are you feeling about that, having everyone coming to your patch?
Incredibly excited, very proud, quite daunted. We've got to pull this off, but it's a fantastic opportunity. We're so excited really to showcase the amazing talent and innovation that GPs across Wales are doing all the time. So it's really exciting.
Like everywhere in the UK, general practice in Wales is under huge amounts of pressure. What has the RCGP been pushing for in discussions with the Welsh Government? What do you think needs to happen to address some of these challenges in Wales?
Well, this is a big question for us at the moment because we've got hotly contested elections coming up in Wales in May 2026. So we're going to release our manifesto at the conference. And our message is really clear. General practice is in crisis. But general practice is also the solution to saving the NHS. We're calling for three things. We want to deliver relationship-based care, which we've been pushing for quite a few years now. And to do that, we need to ease up the bureaucracy that GPs are having to cope with. We want to expand the workforce. We need protected time for training and quality improvement. The second thing we're pushing for is to build healthy communities. We want to modernise our practice buildings so we've got enough space to train from them so that patients have a good experience. We really want to scale up the preventative agenda, more social prescribing. And we want to plan our towns in Wales with health in mind, so cleaner air, green spaces for people to spend their recreational time in. And the final big push that we've got to ask for is for general practice to be properly funded. over 90% of NHS contacts, but ever reducing amount of the NHS budget, which is crazy when you think that every pound that's spent in primary care releases £3 more effective than that spent in hospitals. So we really want Welsh Government to back general practice and invest now before we all collapse and more practices close.
We've talked a lot about the challenges facing general practice, but how do you feel about the future of the profession? You've always struck me as a very positive person. Do you think that the future for general practice is positive?
You're completely right. I'm a born optimist, and I wouldn't be in this job if I didn't believe in the future of general practice. At its heart, it's still the most human part of the NHS, and every day I see the difference that relationship-based care makes. And yet I'm still very hopeful. We've become a training practice now, so I see the next generation of GPs and nurses and allied health professionals, and they are brilliant. You know, they're passionate and innovative. It is tough, but we've got a huge opportunity now to build something even better if we keep making the case, telling the stories like Polly did in A Fortunate Woman, keep working together. I think we can get there.
I'm really pleased to be joined now by Dr Richard Vautrey, who's the outgoing RCGP president and a GP from Leeds. Thanks for coming to talk to me, Richard.
That's my pleasure.
You're coming to the end of your time as president of the college. The president role is actually going to be renamed as provost, isn't it, soon? And the chair role is going to be named as president to bring the RCGP in line with other royal colleges. But what has your role as president, or soon to be provost, what does that role actually involve?
There is a change to take place, and that's because of the confusion that can sometimes arise when others who are outside the medical profession, or indeed in the medical profession, look at other colleges. So if you were to go to the Royal College of Physicians, Royal College of Surgeons, anaesthetists, their leader, the person who's in charge of policy, is the president. And yet within the Royal College of GPs, it's the chair. And so Kamila has been our leader, and has been the chair. And sometimes I'm asked questions because I'm the president on the assumption that I'm the leader of the organisation. But my role is more like being the mayor. I get a nice gown, I get a chain, but I'm more of an honorary position. So my role is both supportive of the officers and the other teams or members within the college, but it's actually some of the nice bits that we get involved with. So it's things like officiating at ceremonies, speaking at various events on behalf of the college, but it is more like being the mayor, whereas Camilla's role is more like being the leader of the council.
And normally, in your role as well, it's traditional that you normally do one of the speeches right at the end of the conference. I mean, this episode of the podcast will be coming out sort of towards the end of today, probably just around the time you're speaking. Can you say anything about what you'll be talking about in your speech, or do you want to keep it all as a surprise?
Well, maybe I shouldn't keep it as a surprise, because I suspect there'll be people who have to travel some distance. So I'll be surprised if there's anybody left in the room at the end of the conference. But hopefully we will have a good attendance. I mean, I'll be reflecting a little bit on not just my time as president, but on my career as a GP. I've been a GP now for 31 years. I've seen huge changes in the NHS during that time. And yet what I've seen throughout it is the resilience of GPs to respond to whatever situation they find themselves in. And GPs can make most systems work, whether they like it or not initially, and often they don't like it initially, but they find ways to make it work, not just for them and for their practice, but primarily for their patients. And if we're given long enough and we have the funding to enable it to work well, then GPs can do remarkable things, working with their teams, and increasingly we have larger teams now of people working and supporting with us. But we are able to do incredible things in a way that many other elements of the NHS simply cannot achieve, because of our flexibility, because of the inherent nature of our contracts, and particularly because of the partnership contract, which enables us to be embedded in the community in a way that makes us accountable to our patients on a day-to-day basis.
You've been a partner for many, many years. Are you concerned about any of the direction of travel with the 10-year plan and these new contracts?
I want to ensure that the partnership structure, which is not just about partners, but it's about being accountable to local populations and being responsive to local populations, remains at the core of general practice. And so one of my worries would be is that if we have new single neighbourhood contracts, that would be at the expense of the partnership structure and the independent contractor arrangement, which I think has really stood us in good stead and has allowed us to be responsive in the way that we need it to be over many, many years. So I hope that will continue, and it isn't an either or, it becomes an opportunity to provide greater cooperation, coordination across a local area in a way that many of us would like to see. When I first joined my practice 31 years ago, when I walked through the door, we had a social worker, we had a district nurse, we had a health visitor, we had a community psychiatrist, all working in the same building, meeting with us over coffee, engaging with us in a way that we just don't see anymore. And that's really what we need to recreate. We don't need to focus on great new buildings and new contracts. What we need is to ensure the collaboration and the cooperation of teams is there, but those other elements of the team have the capacity as well. So we all know that our community nursing teams, social work teams are already overstretched. We need them to have the capacity to be able to respond as well to this changing landscape, where we do know and all recognise that the more we do in the community, the better patient outcomes will be.
Do you have any views on what Stephen Kinnock had to say yesterday at the conference? Because that was quite a robust speech he delivered.
Stephen started well,
Yes.
in terms of the praise of general practice and the recognition of the pressures that we face and the challenges that we jointly have to deal with. Some of his comments focused on the concerns that have been raised by colleagues around some of the government's initiatives, when in reality we all want the same thing.
Yeah.
We all want to ensure our patients get as good as access as possible, but I would hope politicians really do genuinely listen to the profession when they are raising concerns about capacity, about the workload pressures, because if you've got a workforce that is really struggling with capacity and feels that every day is a really hard day, and ultimately that means that they either reduce the number of sessions to actually cope with the workload, or they leave the profession altogether. That's no good for the profession, it's no good for the NHS, and it's no good for our patients. So we need to work with the profession. What I would like to see in the future is any government to recognise that if you enable more GPs to work within the NHS, work within general practice settings, you will deliver more continuity of care because GPs will have more time with their patients. That will deliver better outcomes. It will make the NHS more affordable and ultimately deliver a better service for everybody.
You're a former BMA GP committee chair, and I know the college doesn't get involved with anything to do with the GP contract, but are you able to talk about your own personal views on this dispute over online consultations? Do you think it is going to cause a lot of problems for practices, and do you support the action the BMA is taking?
I can't get involved in those issues specifically, but I think undoubtedly many practices have found a way to make their systems sustainable, balancing the walk-in ability, the ability to ring in on the telephone, the ability to contact online, and getting that balance right will vary from not only practice to practice, but population to population. There are some populations who just will not want lots of direction to an online service, and they would much prefer to be able to contact the practice directly, to speak to somebody they know, to walk in and get that appointment in the way that they've always had done. But there will be other communities where it'll be the reverse, and they will much prefer to use an online system and find that much more user-friendly and valuable. So I think practices are attuned to what their population needs and what they want. They are on the front line every day, and they'll know very quickly whether they're getting it right or wrong. We have to accept that some days will be busier than others, and some days a practice does need to be able to say, actually, we have reached capacity. It's not safe to actually do significantly more. Of course, we will always see the child who is presenting with symptoms that would suggest they need to be seen there and then, or the patients with palliative care needs who actually needs that home visit, even late in the day. We'll go and do it because we're GPs and we know our patients need that. But we need to have the ability and the flexibility to be able to say, this patient probably can manage tomorrow, we don't necessarily need to see them now. I think we also need to learn from some of the initiatives in the past where governments invested a lot in walk-in centres. And there was this philosophy of everybody needs the opportunity just to be able to walk in off the street, they can get their treatment there and then. What happened was that was not cost effective. We ended up duplicating services. Patients were going to a walk-in centre and then later in the day or tomorrow going to see their GP with the same symptoms. So the real benefit for government is to properly invest in core general practice.
Yeah.
Give GPs the funding to employ more GPs and then you'll get a better service.
Yeah, and just before we finish, what have you enjoyed about the conference?
I think the conference is so positive. I think that's been the real joy. I think you hear a real buzz in the rooms that we're having, and there is a real sense of positivity about general practice. Here we've got over 1,000 GPs who want to be GPs, who like being GPs, and have come to learn about how to actually be better GPs as well. And that's one of the key roles of the college, is supporting doctors in their learning and development and encouraging them for the future and for the year ahead.
Well, that's it for this special episode of Talking General Practice from the RCGP Annual Conference. Thanks to everyone who spoke to me for this episode, and thank you for listening. You can read all of our coverage from this year's event on our website at GPonline.com/RCGP. I'll be back next week, so please do join me then.